as promised, I'm going to go ahead and go over the midterm via video since we did talk about this in class. My apologies for the little bit of delay. Again, I will say it. As you all know, my computer has been away from me. If you can't tell, it's been a bit traumatic for me. We don't, I think, realize how connected we are to our devices until we don't have them, especially when it's part of our job. But we're here now and we will do this. So we'll go ahead and start with the first question that I have here. It is a repeat question. True or false? Silence can be used as a form of therapeutic communication. And the answer would be true. That is 100% true. Actually, just experienced this in clinical last week. And one of my students that was there even noticed how it can be quite uncomfortable to sit in silence and you feel like you really want to say something, but in the end, it became very therapeutic because that patient was able to have the time to think about what he or she wanted to really say. So answer there is true. Again, that is a repeat question and we've had it before. The next one also is a repeat question. What is the book called that is used to diagnose mental health disorders? DSM-5. Question 3, this was taken off of the article that we did, and then I had you guys answer questions about it. I didn't add the Abilify part because it didn't have that, just because I call it Abilify, so I thought that would be a little bit more fair, if you will. So Abilify is used as an adjunct medication in managing the following: narcolepsy, depression, or alcohol withdrawal. Many of you did put alcohol withdrawal. The answer is actually depression. For whatever reason, catalyst wise, and I know you have all taken biology and whatnot. So, they just tend to work very well. Not for everybody, of course, as a catalyst on with each other, Abilify and medications. Let's say, or sorry, if somebody has depression and when it says adjunct, that means they have depression, they're on a medication, and then we add in a little bit of Abilify with their antidepressant for whatever reason. And I learned this not that long ago, maybe 5 years ago, and I was just so impressed. So I just want to make sure that you guys know that you have seen this question before, and please note that if you ever see that together. And just as a side note and good reminder, if you see someone on an antipsychotic or on any type of med, that doesn't mean they're taking it for that purpose. Someone can be using Abilify as an adjunct medication with their SSRI. Doesn't mean they're psychotic. It's okay if they are. Nothing against that. But that doesn't mean that they have psychosis. Moving along, 3 patients enter the emergency room. Which of the following is a priority patient that you want to see if you are triaging in the emergency room? We've done this question before. We've talked about NMS being one of the things that can potentially be deadly from EPS symptoms by usage of antipsychotic medications. So we have seen this before. The reason it's not the one here has to do with the patient states that they don't feel like hurting themselves at this time, and they are with a sitter. And of course, we want to treat the tremors, but that's not life or death. So remember, board exam, safety, NMS. And that's a repeat question as well. Next one, another repeat question. And it has to do with feeling something crawling on yourself. What is that? That would be tactile. Short answer, 5 hallucinations. Y'all got that right. I'm almost 100% sure. We know it's visual, olfactory, gustatory, auditory, and tactile. And I think you also, I think everybody spelled it right too. I was very impressed. Next one being a few answered, actually you guys were the class out of the 3 that I gave this question to that most of you did answer both of the questions. Unfortunately, if you notice you only got 1 point, it's because you didn't answer both questions. There are 2 questions here. One is a delusion is a false fixed belief and is often associated with, and then I asked name something in class. I was looking for something like CIA, FBI. But if you put something else and it fit what it is, absolutely, I gave it to you. We talked about the pill and thinking it's poison. I got a couple other ones, but it was still factual. Of course, I'm going to give you the point. It doesn't have to be exactly what I say. True or false? Cogentin is a medication that can help with EPS symptoms such as tremors, lip smacking, tongue rolling, etc. We've talked a bit about Cogentin. So I felt really good about this question. So yes, this is absolutely true. Cogentin is a medication that can help with EPS symptoms. Remember that cogentin is not an antipsychotic. It is a medication that helps with acetylcholine not moving so fast in your brain, because that's what acetylcholine does in your brain. It moves nerve impulses back and forth really, really fast. Cogentin slows down that acetylcholine, making sense that it would help with EPS symptoms. Our next question we have here is, you're an LVN working with a patient who states that they have just been diagnosed with schizophrenia, and you're aware that they are doing some research, and they ask you what dopamine has to do with schizophrenia in their brain. Your patient is interested and asks you, does this mean that I have more dopamine or less dopamine in my brain if I have schizophrenia? What is your answer going to be? It's increased. Remember, if you have schizophrenia, it's more dopamine. You take the antipsychotic, and then that lowers the dopamine. Next would be, you have a patient who is not being compliant with her antipsychotic medication and would like to have a suggestion to help the compliance to the family member who is with the patient. Which medication would you recommend that lasts for 3 months? We know Haldol can be given by injection. Cymbalta is not an antipsychotic. Abilify is an antipsychotic and also can be given by injection. But Haldol and Abilify only last 28 days. And Vega, we've mentioned several times, can last either 28 days, 30 days, I just say 30, or 3 months. So that's kind of the outlier. So I think that's important to note. Next one is also a repeat question, and it goes against, I think, everything we've always learned, but I like this question because I think it breaks that. It doesn't have to be, because we don't want to interrogate. So not all therapeutic communication must be open-ended. I can ask a question therapeutically and it be a question where I'm not asking something open-ended. We prefer open-ended because we can get more information, usually from a patient, especially if they're not really in the mood or maybe not want to talk to us or they're not feeling at their best, right? However, you can still be therapeutic and ask a closed-ended question. So I just want that. I'm just trying to make that clear. So yes, in general, we try to ask open-ended questions, but they don't necessarily have to be. So therapeutic communication does not always have to be open-ended questions. Number 12, which of the following is considered an SSRI? We know that Cymbalta, Effexor, and Prozac are all, remember, there's only 3. So we know those 3 are SNRIs. The last one left is Prozac. And remember, our 3 that we just chose to use are Prozac, Lexapro, and Paxil. So our antidepressant here that is an SSRI will be Prozac. True or false? General anxiety and depression are often diagnosed together. We talked about this in great deal, having to do with the medications that are prescribed. Unfortunately, I saw an ATI. One of my students actually pointed it out to me. It's completely wrong. So if you come across it on ATI, it says it can actually cause anxiety. It can cause more anxiety, or it says it completely wrong. It gives a complete wrong answer. I promise you that general anxiety and depression are often diagnosed together, because it asked about, like, I can't remember, something about a medication and SSRI being given. What could that potentially cause? And it talked about it could actually make the patient more anxious. So if that comes across, that is 100% not true. I have evidence-based practice to show that. And again, why would you make a medication, SSRIs, SNRIs specifically, and newer ones specifically to treat both general anxiety and depression? For the reason of it being that they are often diagnosed together. And if you were in Miss Linda's talk in clinical, when I was doing her evaluation, she talked about usually why it leads to depression, because anxiety being so exhausting, and we talked about a lot about it. She did a fabulous job. And then that can lead to such exhaustion and just hopelessness that depression happens. So an individual calls the crisis hotline. We went over this one before as well. This was a lot of these I took from our NCLEX questions, because I think those are very important. And basically, the patient unfortunately says, it's over. I've done all I can do. What is the best thing you're going to say? We always think about safety. So we're going to ask, are you thinking of hurting yourself? Tyramine should be avoided if you are taking what type of true or false? Tyramine should be avoided if a patient is taking an antidepressant in the MAOI classification. Absolutely true, 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 true. Please, please, please know this and know a couple of the food, like, fermented meats and wine and things like that, because on your NCLEX they may ask you. So when you're studying for your boards, you'll study psych. It'll be a part of your package. Make sure that you have some examples. Several days after being admitted for depression, a client sits alone in the dining room. The nurse notes that the client has not finished the meal. Which action is best? Remember, we are in the NCLEX world. It is perfect. You have all the time in the world. What is going to be the best thing that we need to do? We need to assess, because we don't know why this patient's not eating. So the best one would be sit with the client during meals. Therefore, we can hopefully find out what's going on. Do they not like the food? And that's what the other three have to do with. And this is a repeat question as well. And when I say repeat, that doesn't mean it was necessarily on a test. That means we went over it in class together, because it was an NCLEX question that I had you practice, and then we went over it. Okay. A patient has been diagnosed with anxiety and wants to utilize medication, but does not want anything that is potentially habit forming, and reports not having done well in the past with SSRIs or SNRI medications. Which of the following medications might you expect to be prescribed to help this patient with anxiety that is off label? We talked about before the test. Several of you got this wrong. So I do really want to, if you are listening to this, and if I remember to say it, really urge you to, you're all paying attention. I mean, I see that, and I know it's a long day. I really, really do. But I repeated this, and I actually will write down sometimes. I repeated this 6 times over the course of 2 different classes, that I'm going to ask one question on anxiety medication, and it's going to have to do with off-label. And it will either be gabapentin, propranolol, or hydroxyzine. So Valium and Ativan, those are not off-label. Those are anti-anxiety medications. Cymbalta can be used for anxiety as well, but that's not off-label. Propranolol is the off-label medication. Again, I said it in that order. I said gabapentin, propranolol, or hydroxyzine. So the answer there, off-label, propranolol can be used for anxiety, because propranolol is a beta blocker that's used to lower the heart rate, therefore lowering anxiety. Short answer, a patient is reporting to be having somatic symptoms of anxiety. Please list 2 somatic symptoms of anxiety. I'll name a couple. Sweaty hands, upset stomach, constipation, diarrhea, muscle tension. You guys did well on that one. You guys did well overall, by the way. I think I said that in class. Which of the following medications are all considered to be SNRI medications? Selective serotonin norepinephrine reuptake inhibitors. Again, we've mentioned them in class. The 3 that we use for SSRIs that we just kind of remember are Prozac, Lexapro, and Paxil. The SNRIs are Effexor, Cymbalta, and Pristiq. True or false? An illusion is mistaking one object for another, such as a remote control for a cat. That is true. Psychosis is a detachment from reality. There were a couple of different wordings. Of course, I gave it to you because you were correct. True or false? You must have schizophrenia to experience psychosis. We know that's not true, but you will have psychosis if you have schizophrenia. We've talked about that in class a lot. Next question. A patient states during an assessment that they are feeling SI, which is suicidal ideation. What would be the best question to ask next? We always want to ask, do you have a plan? That is always the next question that you ask. Where is 10% of serotonin in your body? So we know that we have 90% in our gut, so 10% is in our body. Unfortunately, and I wasn't trying to confuse you, I put the question backwards this way because I want to make sure that you're reading the question, because on your board exam, I'm trying to kind of train your brain to really look at the question. So 10% is in the brain, not the body. Antipsychotic medications can cause a granulocytosis, causing a higher risk of infection for those taking an antipsychotic. That would be absolutely true. We know now less side effects for the newer medications, but it can still happen. That's why we test the blood and make sure that the WBCs are doing well, the white blood cell count, because we want to avoid infection. True or false? SI and HI stand for suicidal ideation and homicidal ideation. That is true. Homicidal ideation meaning thinking about hurting someone else. Suicidal ideation meaning thoughts of harming yourself. Up to how many hours is a 5150? That is up to 72 hours. I will say I was slightly disappointed because I would say about 35% of you did not get this correct. And we did go over it quite a few times. So please, again, if you're finding yourself in a place where you're sitting, maybe where you're having trouble concentrating, or I know that, again, that's kind of an odd time of the day and you just get done eating and you're probably full or tired or whatever it may be. I really want everyone to, and everyone's doing very well in this class, but I want you to retain as much as you can so that I can set you up with the best foundation to pass your board exam. So up to 72 hours. Short answer. What neurotransmitter this isn't a short answer actually, but what neurotransmitters do SSRIs interact with? We know that would be serotonin. What two mental health diagnoses can Lexapro be used for? We just mentioned it right now, earlier, a few minutes ago, depression and anxiety. So we know that it can be used for both because we know that anxiety and depression often go together, and Lexapro is an antidepressant and it is an SSRI. A 26-year-old male comes into the mental health clinic and states that he is feeling anxious and having trouble sleeping. Which medication that is classified as an anticonvulsant might be viable for this patient? I have talked about this medication 9 times in class. I make a little tally to make sure. So this medication we're talking about is gabapentin. It's an anticonvulsant. That is its classification. And again, in class, we talked about that gabapentin, propranolol, and hydroxyzine can all be used for anxiety. And we've talked about gabapentin a lot, being an anticonvulsant, and what are 2 other things we can use it for. And we talked about agitation, anxiety, insomnia. So the answer there would be gabapentin. Which of the following medications was originally made for depression and is now used for sleep? We talked about this, and it was in the Jeopardy game. That is trazodone. Trazodone, we do not use it for depression anymore because in order for you to reach your therapeutic dose, you have to take 400 to 600 milligrams a day. Unfortunately, most people would just sleep all day. They're not getting quality of life. That's not our goal of treatment. So we use a smaller dose, something like 50 to maybe 150 milligrams. Therefore, they're getting the benefit of it. It's not considered to have the potential to be addictive because it does not release dopamine in the reward pathway. Next one being, what 2 diagnoses make up schizoaffective disorder? That would be schizophrenia and bipolar disorder, and or schizophrenia and mood disorder. Your patient asks you why medications that interact with serotonin can cause stomach upset for the first, sorry, I didn't put the rest there, or so. What is the reason? No one came up and asked me the question, so I'm assuming everyone understood what I meant there. And what is the reason? It's because we know that serotonin in the gut is also being activated. So because there's 90% of it is in the gut, so it's going to be activated as well. Hopefully that will subside. If it does not, then the medication could be changed. That's something that does not interact with serotonin, that is still an antidepressant. You are reviewing medications with your patient and notice that they are taking a medication that interacts with serotonin and also some supplements, one of them being St. John's wort. Why is this combination a possible contraindication? And that has to do with serotonin syndrome. I had half and half. I had tyramine overdose and serotonin syndrome. So and this is one of those ones that will pop up on the, just like the tyramine and the MAOIs. That's a very common question as well. So please keeping in mind that St. John's wort is a medication. It is sold over the counter. It is a supplement. And it does interact, and you don't have to remember this, but just we're doing this, might as well tell you. Basically, what it does is it activates 5-HTP in your brain. And 5-HTP is the precursor for serotonin, because things over the counter can't just go straight to something, right? Just like you can buy stuff that helps with GABA production in the brain. It's not gabapentin and it's not it's hitting the precursor to gabapentin. So same thing with this. So St. John's wort goes to 5-HTP that stimulates serotonin, therefore causing more serotonin. And if you're already taking something with serotonin, that can potentially be dangerous. So that can cause serotonin syndrome. Not deadly, but not comfortable. Why do we not stop antidepressants abruptly? Many of you put rebound hypertension. I was not trying to confuse you. It's because of possible suicidal ideation. We had talked about that in class, that it's like rebound hypertension, and I could have put rebound suicidal ideation, but I really, again, wanted you to read the question. I only put 2 on there that were a little bit, not confusing, but I think kind of like flipped a little bit in the way that I had said it, but it still meant the same thing. So please keeping in mind that's a black box warning of antidepressants, especially for those that are ages between the ages of like 18 and 24, I believe it is if we stop abruptly, number 1, you're not going to feel good. And number 2, you can possibly have that rebound suicidal ideation or just have suicidal ideation, even if you didn't have it before. Short answer. What does it mean if a medication is used off label? We all know what this means. It means that it's a medication that was made for one thing and we use it for another, that it was not originally intended for. True or false? Wellbuten's classification is an antidepressant. That is absolutely true. Yes. We didn't talk a lot about Wellbutrin, but it was on your study guide. And of course, it can be used as an anxiety and just for fun. It can also be used for ADHD and for smoking cessation, meaning stopping to smoke, just for fun, just to let you know. True or false? On average, it takes 6 to 12 weeks for an antidepressant to start working. A little bit disappointed on this one too. So no, remember, it's either 2 to 6 weeks or 3 to 6 weeks, depending on whomever's asking you. 6 weeks is kind of that threshold. If it's not working at that point, we kind of have to look at it. Okay, do we need to up the dose? And we may be upping the dose even at week 3 or 4, but that's where it hits its therapeutic level is 6 weeks. So the answer would be here false. It's 3 to 6 weeks or 2 to 6 weeks, depending on who's teaching you. True or false? Death can occur if a patient is on an MAO, and I'm supposed to say I, if a buildup of tyramine is to take place. Absolutely 100% true. So MAOIs naturally cause a buildup of tyramine in our body. So then if we're adding tyramine to our body, that's what can cause all of that stuff going on, like the seizures, the coma, and the death. Extra credit question. I gave you all 2 free points, actually. It says 1 here. Or maybe I gave you 1. I can't remember. I gave you 1 or 2. I can't remember. Sorry. Just for being awesome. I didn't even ask you a question. So I hope this was helpful. And again, please write down any questions if you have a question or, something that you want to discuss about it. I'm more than happy to, of course, do that. That's why I'm doing this video, because we don't have a very long class. And I want to make sure that everyone gets their questions answered. Thank you so much.